or even the younger population in terms of Ramsay Hunt, where you get herpes zoster, obviously as there and then by the patient and the family members as to the physician who's making the diagnosis, whether it be a diagnosis for a surgical procedure, let's say to remove a lump from the breast, to remove the entire breast, to remove a portion of a gallbladder, to remove a portion of a diseased liver, to remove a portion of a gut because of either infection from chronic inflammatory disease of a small gut, or to remove part of the colon based on the simple fact that you have cancer of the colon. The family should be involved in this and go to the physician who's making the diagnosis, the surgeon who's going to be operating, and asking all the pertinent question that goes with it. Here is my relative, my mother, my father, my brother and sister. They're not as fluent in English as I am, and basically the level of structured education is not as in my case. So I'm asking you now, can you explain to my relative exactly what the procedure is going to be? What is the procedure is going to be made from now? Have we made the diagnosis? What is our next step? Why are you sending us back to a primary care physician for clearance? Why do you need an additional EKG to be done? Why do you need an echocardiogram for the patient to be cleared for surgery? Why do you need a repeat blood test the week prior to surgery? Why is it that I cannot have nothing to eat prior to coming for the surgical procedure? And why is it I need to take my blood pressure tablets and not my diabetes tablets? I have no problems in explaining all the steps to patients, but I also want you to hear twice. First from the surgeon who's going to be operating on you, and then I can further enhance what he's saying by making it repeated to you, especially very simply, and to make sure you understand what is going to be done. Let's take this particular patient. The patient did not ask the gynecologist exactly what the procedure is going to be entailing. Basically, just say, well, I will send you back to your primary care physician, which in that case was myself, for clearance for surgery. Now, I think she said she just walked out without even asking any questions because she was in shock. Fair enough. But understand, too, is that it's an entire family being involved here. And your daughter, who is, I think, a nurse, should also have been involved in the process of decision-making, as well as to ask the gynecologist, is this, my mother has been diagnosed as cancer of the ovary. Is it a stage 1, stage 2, stage 3? What is the prognosis? What is it we're doing? Because when she came to me, she said, doctor, they plan to take out everything. If they take out everything, meaning the uterus, the fallopian tubes, the ovary, the portion of the cervix, but the entire cervix, and a portion of the upper vault to the vagina, am I going to be sexually active after that? What is my outcome in terms of how I'll feel afterwards? Will I become bloated? I hear when you remove your uterus, you have no desire whatsoever for the normal things that you pride yourself in life about. She thinks of herself as being less of a woman. Those are things that could be answered in a very fair manner to the patient in terms of our experience as clinician. But albeit enough to say is that the surgical procedure, there's no ambiguity in the mind of any clinician what needs to get done. In the case of a diseased portion of the pelvis, you need to do a total clearance of the pelvis. Let's say, for instance, this was just a uterine fibroid in that of a young woman who has not reached her childbearing potential. Then she'll be signing for, let's say, a myomectomy, which is removal of a fibroid within the uterus. But let's say, for instance, the fibroid was in the uterus and you had to remove just a portion of it. Let's say there was a small fibroid within the uterus and removing a portion of it, let's say within that area. Then basically what you're faced with is that you could do a myomectomy going through here, burning out that fibroid. This is not the diagram for it, but just I'm saying for argument's sake, this was where the fibroid was. That could be removed. But when you're signing for a procedure that has to do with the removal of the fibroid, you also are going to be signing a declaration that says to you, you're giving consent to the surgeon in the event of an unlikely outcome to have a total abdominal hysterectomy, a bisalpingo-oophorectomy, which is the removal of the entire uterus, cervix, and the ovary in the event it becomes necessary. In the majority of cases, This option is never exercised by the surgeon. But it's an event that your life be, for some reason, whether it be compromised by the fact of the tube itself being larger than it is, or the fact that you're bleeding from an artery or a blood vessel that's basically was never anticipated prior to surgery, you have to sign a consent to give the surgeon the right to remove it if he feels it's necessary, if it's disease, or to preserve your life, just so you get an unlikely outcome, that you develop an abnormal cardiac rhythm, an abnormal heart rate that puts your life in jeopardy. And the fastest way of getting out to save your life is by clamping the larger blood vessels. You have to sign something that says to you, you'll be limiting the operation to a myomectomy, removal of the uterus, removal of the fibroids, or as I say, removal of the uterus itself, but you're sparing the ovaries, etc., for whatever reasons you choose. But the procedure is always going to be to sign for the maximum that needs to get done, which is total pelvic clearance. In the case of this woman, she had no problems with it because she had reached her childbearing potential, and she already had a diseased cervix, a diseased uterus, and diseased ovaries, and she did not want to use them any longer. So always at the point in time, when you're visiting the surgeon, take one or two of your relatives and ask all the questions that are relevant to that particular operation and how it will affect life after that operation. Continuing our discussion on the case of the woman who was referred for surgical evaluation of the cancer, of the question of a cancer of the ovary, but a confirmed diagnosis of uterine fibroids, and who was told that she needed to have had a surgery to remove the entire uterus, fibroids, the fallopian tubes, which were painful during intercourse, and the ovary, which was cancerous, and also the mouth of the cervix, which had evidence of cancer but was treated with a cone biopsy. The important thing to realize here is that surgical procedures are not done at random. They basically haven't made the decision this was the only alternative for cure, or attempt to cure, or attempt to make a proper diagnosis. A surgical procedure, limited surgical procedure first, and then maximum if it needs to be. In this particular patient case, there was only one alternative, and that was an explorative laparotomy, meaning opening up the abdomen with the smallest incision from the umbilicus to the pubic symphysis to get access into the abdomen. It's by getting access into the abdomen, the lower portion of the abdomen, is the surgeon then able to evaluate the uterus, the fallopian tubes themselves, the evidence of if there's any spread of cancer along the lymphatic system that drains the ovaries, that drains the uterus, that drains the tube, that drains the entire pelvic system. So the only way for the clinician to actually make the proper diagnosis and make sure it's curative in the event it is to be able to look inside of that abdomen. You look inside that abdomen, you manipulate and move around all the organs. You feel for the texture. You use your experience to see whether there's enlargement. How does it feel? Does it have a normal feel of a uterus? Does it have a normal feel of an ovary? Then you know before you get into the operating room that basically you know what the procedure you have in mind. But you have to have the consent of the patient to do the maximum for your benefit, rather than have to do a two-stage procedure, meaning I got your consent just to remove the tubes or the ovary because that's where the cancer was. No, I need your consent that if in the event I go in there and I find there's evidence of a diseased uterus, or I find your bladder has evidence of metastatic spread, then I should be able to do it at one stage to be able to repair this or give you the best possible chance of an outcome based on other adjunctive methods other than surgery, whether or not radiotherapy, whether or not chemotherapy, based on the fact that when you go into the pelvis or you go into the abdomen, you're able to visually look at the areas around it and then make the diagnosis as to whether or not there's lymphatic spread. There is no test that is good enough at this stage other than direct vision when you're into an abdomen. And then you can biopsy stuff that you see that looks abnormal. And even if you biopsy it and you don't get the diagnosis then, you're able to make the difference, you're able to make the diagnosis subsequently whether or not that cancer has spread to involve the abdomen, which takes it up to another level. Because if it's restricted to the pelvis, it is sometimes considered curative even with adjunctive radiotherapy. If it has spread to the abdomen involving the liver, it's as good as saying goodbye. If it involves the thoracic region, definitely it's terminal, and basically those are the things we use for diagnosis. Nothing is intended at any point in time to overdo a procedure for the benefit of the surgeon, because there's no monetary incentive, there's no other incentive for that individual to pursue in that direction. That's why it's important when you go to the clinic, to go to the surgeon, you also ask their input as to if there was further spread, what would you do? Would you biopsy it any further? What would you do with a case like, say you got a cancer of the colon, and you tell me you're going to do a resection of the colon, reanastomose it, and we should be back to normal. Or you do it in a two-stage procedure. Resect resect part of the colon that is diseased, bring out the anastomosis, bring out the openings on both sides, and basically be able to feed by a colostomy. I know a lot of us have relatives with cancers, cancer of the large bowel itself, and basically you see them have these feeding to these bags, these colostomy bags. But a lot of times it is just, sometimes it's temporary, sometimes it is permanent. So it's important for us to know what the procedures and be able to know what we're consenting to. And obviously in the interest of, I told this woman that definitely as part of a medical procedure, you have to have clearance from the primary care physician who says that you're fit for surgery. If you're fit for surgery, it means you are going to be exposed to a mild to moderate risk for surgery as anybody of your age, of your disease process. Your EKG at rest looks normal, your blood test looks normal, your EKG doesn't show any evidence of an abnormal rate and rhythm. Your echocardiogram does not show evidence of a decreased ejection fraction, which says to you that under the stress of surgery that you will undergo a cardiac event. Maybe you'll need to be evaluated by the cardiologist to see whether or not a stress test, whether it be thallium or exercise stress test, is needed for you to undergo the stresses of surgery. If your blood count is low, is your hemoglobin so low that we need to at least be able to give you packed red blood cells? Or if we know the surgery is scheduled for a month from now, we can start you on iron tablets. Do we think there's any other source of cancer within you? Do we need to get a colonoscopy done for you? Do we need to get a CAT scan of the abdomen to see whether or not there's any metastatic spread prior to you going for surgery? We repeat the blood test the week before surgery, because we want to make sure your things have been maintained. Not only that, your blood count plus your electrolytes. If your potassium level is low, you put yourself on an abnormal rhythm for surgery, an abnormal rhythm that can be precipitated by general anesthesia. So it's very important that you know what your biochemistry profile is, your hematological profile is, you know what your recent EKG is, you know what your bleeding disorders are. You know that at least there's no other organ system involved, especially in us who smoke, especially in us who've had other coronary artery disease or other cardiac disease. We make sure that those are stable. We make sure we don't have any other processes, whether it be infective or non-infective, that's going on. We may have a urinary tract infection that can make the surgery even become worse than it is, because we can become much more unstable operating table. So these are things you need to be cleared for surgery that says to the surgeon, doctor, in my experience of knowing this patient for the last 5, 10, 15 years, this patient has been stable, and I will say that this patient is mild to moderate risk for surgical procedure that involves a total abdominal hysterectomy or bisalping oophorectomy or a colectomy or whatever surgical procedure is being anticipated. It's not an emergency surgery, it's an elective surgery. Even though it's emergent, you still have to act in a prudent manner that says, I am not going to be putting my patient at increased risk by having this procedure done unnecessarily a day or two before it becomes necessary. The issue about that is your physician is held to a higher standard to act in the interest of the patient and only in the interest of the patient, to say that I've done the best I can to make sure that the surgical procedure, which is deemed to be elective, is done for the best interest of the patient in an optimal condition with optimal patient benefits and everything optimized from every system that you could think of, the cardiac system, the pulmonary system, the hematological system, whether or not there's any evidence of infection. So at all times be prepared to come to your physician with questions, and those questions should be answered by the surgeon and your primary care physician at all times to make sure that you are comfortable going into surgery with your relative.